we'll go on to the next one. So we've done with malignancies in and around the eye. And now we go to what happens when you have metastatic disease into the eye. So these are no longer primary malignant tumors. The other thing I was thinking while Divya gets ready with her talk is that all of us base our prognosis on what the literature says. And it's so often defeatist because whenever I think of intraocular lymphoma, I think of death. I never think of people surviving. And when I think of retinoblastoma, my patients have survived, but with enucleation. So I'm sure that over a period of time, with all the work that is going on, including by all of you, the future generations will no longer see these as absolute harbingers of death or blindness.
Okay, thank you very much, Madam and Sharika, for giving me this opportunity. So my talk is about metastatic ocular tumors. So what is a metastasis? We all know the spread of cancer from the place where they first form to another body part. So the eye as such is a very rare site because there is less lymphatic, there's an absence of lymphatic system, and it spreads by hematogenous spread, and the parts of the eye which have the most vascular supply are affected. And thus the most vascular supply in the eye is the uvea, and the uvea is the most common site, and in the uvea the choroid forms the major part. So mostly I'll be talking about choroidal metastasis, first documented in 1872, but now it is the most common intraocular malignancy in adult population. And the primary source is a breast cancer most commonly, and followed by lung cancer. And when there is no primary site, and the workup will ultimately more commonly lead to a lung cancer. So the pathophysiology is hematogenous dissemination of tumor cells. The posterior ciliary arteries in the eye provide great flow for tumor emboli, and they are the most common causing posterior choroid metastasis. So pathophysiology mechanism, there are multiple theories proposed: the anatomical mechanical mechanism, seed soil mechanism, and the wound oncogen wound healing model. I'll just go through them. The anatomical model says that the first anatomic site, which is downstream of the primary tumor, has the higher frequency of metastasis. So in the eye, the posterior ciliary arteries causing posterior choroid having more metastasis. The seed soil mechanism says that the seed, that is the tumor cells, should need an adequate microenvironment, and this microenvironment is provided by the organ with the most vascular supply. The wound oncogen model is a new model where they say that the cancer is a result of the attempt of the body to heal a wound, and this abnormal wound are the oncogenes which get activated, causing metastasis. So signs and symptoms of metastasis patient generally presents with blurred vision. They can also have flashes, floaters, or occasionally pain, and very rarely they have no symptoms and are just found out on routine ocular examination. So they are generally appear as creamy white, pale yellow masses, subretinal lesions. You can see the retinal vessels over these lesions. They are all subretinal. Their appearance is flat or plateau shaped. We can sometimes think about the primary on looking at the morphological features of these. Like in the first picture is of a lung carcinoma where it appears pale yellow color. For breast cancer, the metastasis may appear like lobular. And last is the prostate cancer where it can be seen as a melanotic mass. Sometimes they also present similar to a lymphoma, like with the leopard spot pigmentation. They can be bilateral, they can be multifocal. Then laterality has also been debated in multiple studies, where they say that the left eye was more commonly involved because it has a more direct pathway to the eye from the aorta. So the main thing when you see these choroidal masses is to differentiate them, whether they are malignant or whether they are benign. It can be a malignant melanoma also, or it can be benign tumors like an osteoma, hemangioma. Even a CNVM can look like a choroidal metastasis. The most common feature which is seen with this is subretinal fluid. In contrast to a melanoma has to become very large, very huge to have a exudative retinal detachment, where here even smaller lesions can cause subretinal fluid. Multimodal imaging, of course, comes to our help, where fluorescent angiography and ICG can be done. The top pictures are of the fluorescent angiogram, where the fluorescence will show stippled hyperfluorescence with minimal leak. ICG is generally seen as a hypocyanine lesion. But this multimodal imaging may not, just the angiogram may not help us in differentiating them from melanoma or other tumors, because all of them will appear hypo on ICG. The B-scan ultrasound is a better modality, where the choroidal melanoma can shows inner low reflective echoes. because there has more necrotic tissue, whereas metastasis will show hyperreflective or moderate reflective echoes compared to a melanoma. EDI OCT is a non-invasive and very useful investigation where the few characteristics are described. It shows lumpy, bumpy appearance. There is swelling and shaggy photoreceptors seen. Subretinal fluid can show hyperreflective dots called as speckles. So always, if the primary is not known, there is very important to look for the primary. Take a thorough medical history, do a physical examination, or even a PET CT scan, and collaboration with the general physician is very important. And how to manage these patients, the decision to pursue the therapy for choroidal mets is multidisciplinary. It involves a patient oncologist and radiation oncologist, and also the overall health and life expectancy of the patient is also very important. Complex treatments are generally not advised because they have sometimes limited life expectancy, and at this point they may have synchronous other metastasis like the liver lung mets, or they may have CNS metastasis. So in case of an isolated choroidal metastasis, a local treatment can be considered upfront. But when there are multi-system metastatic disease threatening survival, then chemotherapy and systemic therapy are more essential for the patient. So systemic therapy nowadays, apart from the chemotherapy, they have targeted therapy for lung cancer, there is molecular targeting. For breast cancer, there is hormonal therapy. And if local modality are used, then radiation or external beam radiation is the most commonly used therapy, followed by plaque brachytherapy. PDT was used before, TTT, enucleation in cases of severe unrelenting pain for the patient. External beam radiotherapy is the most widely used, and 30 gray in 10 fractions is the most common dose used, but it has other side effects like radiodermatitis, focal alopecia. In long term, it can cause cataract and glaucoma. Plaque brachytherapy gives local treatment, and where an isotope is placed on the sclera to give radiation dose. It does not deliver dose outside the eye, so that the systemic side effects can be reduced with plaque brachytherapy. PDT, because the dry verteprofen is not nowadays available, is not used, but previously it was also used for managing small ocular metastasis. Intravitreal anti-VEGF is useful. The anti-VEGF as such, bevacizumab, was originally used to treat systemic cancer. So the intravitreal anti-VEGF monthly doses have been proven in multiple studies for reduction of pulmonary and breast cancer-induced choroidal metastasis. So when we consider the management, first thing is life expectancy. What are the other metastases the patient has? If the life expectancy is short, then go for systemic therapy first, and then if the systemic therapy is not working, then go for the local treatment. If the life expectancy is better, then, and if they have bilateral disease, then external beam radiotherapy is more preferred. In unilateral cases, you can go for either plaque therapy or EBRT, whichever is. Then very rarely we can have iris and ciliary body metastasis. They can be mistaken for uveitis or neovascular glaucoma. And retinal metastasis seen in less than 1% of ocular metastasis. Diagnosis is often delayed and misdiagnosed. So thank you very much. And on behalf of the organizing committee, I would like to invite you all for Ignite 2025, which is going to be held on January 4th and 5th at Kochi. Thank you.
Thank you, Divya. Like I said, time willing, we will have the questions at the end. We always believed that our fate was decided by the stars, but now we know that all that happens to us